Good afternoon and welcome to today's presentation, Third-Party Payers and Mental Health. The information presented by the expert is not to be used as legal advice and does not indicate a working relationship with the expert. All materials obtained from this presentation are merely for educational purposes and should not be used in a court of law since the expert consent, i.e. a business relationship, where she or he is hired for your particular case. In today's webinar, Beverly Price will discuss mental health parity, types of health plans that guide the process, the authorization process, documentation, medical necessity guidelines, and evidence-based practice, the appeals process, and other legal issues regarding third-party payers. To give you a little background about our presenter, Beverly Price is an International Association of Eating Disorders Professional Certified Eating Disorders Registered Dietitian and an International Association of Yoga Therapists Certified Yoga Therapist. Beverly owns and operated a comprehensive eating disorder and mental health treatment center in Michigan that offered partial hospitalization, intensive outpatient and outpatient level of care programs run by a multidisciplinary team of healthcare professionals. Before selling her center to a private company, Beverly interfaced with insurance companies regarding eligibility and benefits, authorizations, denial management, and the appeal process. In her career, Beverly has also served as an expert witness for various food, nutrition, and yoga-related cases. Attendees who require password, the code for today is payers. During the Q&A session, we ask that you enter this passcode into the Q&A widget for CLE reporting purposes. The Q&A is located to the left of your screen. Please remember that if you're applying for CLE credit, you must log onto your computer as yourself and stay for the full 60 minutes of the presentation. You're also required to complete the survey at the end of the program. Please note that CLE credit cannot be given to those watching together on a single computer. Tomorrow morning, we will send out an email with the link to the archive recording of the webinar. The slides can be downloaded from the resource list at the widget at the bottom of your screen. Thank you all for attending today, and Beverly, the big presentation is now turned over to you.
Thank you, Rochelle, and good afternoon, everyone. I'm excited to present on one of my favorite topics, and I hope to present information regarding the third-party care landscape in order to support you as an expert. We're going to start with the Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equity Act of 2008. And this act was enacted in October of 2008. It took effect on January 1st, 2010, and was actually phased in over several years as far as the parity aspects. And the act enacts parity rules for plans that choose to offer both medical and surgical benefits, as well as mental health and substance abuse disorder benefits. And the Affordable Care Act came later, so not to confuse anything, the Affordable Care Act is really when more of the mental health requirements were phased in to insurance plan requirements. So some of the stipulations of this act, and I'll summarize these in each point here, that in the old days, deductibles and co-payments were different from mental health to medical. There were often different co-pays, different deductibles. The mental health may have been more stringent than the medical side. So with this act, co-pays and deductibles have to be of equal. Generally, you're going to find policies now that just have one deductible and one co-payment structure for everything, medical and mental health, substance abuse combined. And as far as cost-sharing requirements, the cost-sharing for the employee, let's say, can't be any greater. Their percent of their premium payment cannot be greater for mental health than medical, always equal. And as far as the restrictiveness in terms of treatment limitations, we used to see limitations of treatment in mental health and substance use. There would only be so many visits allowed. And as compared to medical, both have to be equal. If there are visit limits for medical benefits, they have to be the same on the mental health and substance abuse side. And if a plan provides out-of-network coverage, the plan has to provide out-of-network coverage for medical along with mental health. So it can't just be medical, not mental health. And often we see obstacles even with these parity laws. So even though we have national parity laws, there's state parity laws, there's also mandates. So you may not have a state that actually is a parity state. So although parity laws cover a large aspect, if a state does not have parity laws, there are a lot of loopholes in what the insurance companies can, as far as they can go with coverage or what they choose not to cover. And there are mandates. So for example, in a non-parity state, if a diagnosis is thought to be covered, for example, in Michigan where I reside, there was an autism bill put through, and now autism has to be covered in every aspect of treatment by insurance companies, whereas maybe eating disorders, where I specialize in, does not have to be, and there might be limitations in the type of diagnoses covered from plan to plan. And that's where the different health plan rules come in, because a policy for one, let's say, Aetna, for example, may be different than another Aetna plan. So that's going to depend on how that policy is written and how it's insured. And here are the levels of mental health care. You have inpatient care, which is more for acute psychiatric, somebody that's suicidal, homicidal, and then they may be stepped down to residential care where somebody has to be psychiatrically, medically stable. And when I say psychiatrically, more that they're not actively suicidal, homicidal, and in a residential care setting, the goal is to interrupt the constant behaviors. Whereas one steps down to a partial hospitalization, this is a level of care where somebody can live independently, where they don't need supervision at night. And as they progress into levels of care, intensive outpatient is a shorter treatment day, again, where the patient goes home at night and they're practicing concepts learned in treatment, and then they progress into outpatient care, which is maybe once a week, twice a week with a therapist, a prescriber, and this was a very quick overview of the levels, but you can see how the different levels of care, as we get into this presentation, will guide some of the processes here. Okay, what happened to my slide? Okay, so benefits obtained through the employer is a method of or a means of insurance coverage. And a policy purchased privately through an insurance agent may be for somebody who is employed on their own in a single business, or who is not part of a group. The insurance coverage can be purchased through the marketplace or exchanges on a federal or state-run level. And then, of course, there's Medicare and the supplemental packages that go with that. And these are different types of plan funding. And this tends to get a little bit confusing. So a fully funded plan is where an individual or an employer pays premiums to the insurance company. So, for example, you may work for XYZ company and they offer Blue Cross. And the company is paying premiums per person to the company, and perhaps the employee is paying part of those premiums that are withdrawn out of their paycheck. And this type of plan can also be applied to an individual plan. So generally an individual would be paying premiums. They would be absorbing 100% of the premiums if they did not have an employer. They were self-employed, let's say. And then a state-funded plan, again, the exchange of the marketplace plan. And then the self-funded plans, when we refer to a self-insured company, this is where the employer is going to pay claims on a per-incident basis. So they're actually paying each incident. Let's say an employee goes for lab work or a physician visit or really just about anything that is covered in the policy, the employer is actually paying per incident. They're not paying premiums. And generally, costs over $25,000 per incident are covered by a reinsurer, sometimes higher. And then these self-funded plans are often managed by a third-party administrator, and we call this a TPA. So this third-party administrator might be a separate company that's actually determining what benefits should be paid or not if a service requires authorization. They're there to manage the cost so that the employer isn't just paying out the roof. They're there to really be that gatekeeper. And as far as governing power, the fully funded plan, in this case, the insurer has complete governing power until that case goes to external review. So if there is an incidence of a denial for a service that is generally covered on a plan, or maybe there's so many visit limits based on medical necessity, and this is where things get sticky, where the individual needs more care and the insurance determines medical necessity has not been met, the insurer has complete governing power until this case goes to an external review board. And we're going to get a little bit more into this as well in terms of the external review. And then the state-funded plans, these are generally governed by different state laws. And fighting for care will require litigation often. Now the self-funded plans, these are operated under ERISA, and this is the Employee Retirement Income Security Act. This generally does not have an external appeal option. And again, we're going to talk a little bit more about this. This is just a little overview here. We're going to talk a little bit extensively on ERISA and how it governs insurance rights. So this is a federal law. And if a claim is denied, for example, there's an appeal process that has to be met before the insurer can file a lawsuit. And in many cases, insurers can be given great leeway. And if a plan is covered under ERISA, there are no jury trials. And there are state insurance bad faith laws. Each state has a different set of criteria for when an insurer operates in bad faith. And in an ERISA case, these bad faith laws don't apply. And then the case is subject to judicial review, and then it's limited to the file itself. So no extra evidence can be brought in outside the file, no discovery. And from the appeal process, there are several appeals and then an external appeal. There is no external appeal needed in an ERISA case. And then the remedies are limited to benefits and attorney's fees. So no emotional compensation. There's really no other compensation beyond this. So ERISA imposes higher than marketplace quality standards on insurers. And there is a special standard of care on a plan administrator to reduce the bias, promote accuracy in the process of claims, along with a full and fair review of claim denial. So ERISA is really meant to bring the insurer, the insuree together to really work out when there is a denial. But there are often biases, as you would guess. In an ERISA-governed plan, most group plans are covered by ERISA. So going back to the self-insured plan, also the fully insured plans, the plans that where the employer pays premiums, those too are covered under ERISA. However, government, religious entities, and other nonprofits are not covered under ERISA, and we're going to see how the appeal process plays out in this based on the two different paths. Now, public schools may or may not fall under ERISA. It really depends on how the plan is underwritten, and it really has to do more so with how the unions are organized. And then on the individual insurance side, if somebody just has an individual policy on themselves or family, there are no appeals required before a lawsuit can be filed. The juries make the decision on the case. And then also evidence outside of the file may be considered by the jury. And then in these cases, with an individual insurance plan, and plan not falling under ERISA, the remedies can include benefits, emotional distress, attorney fees, other damages. So here's just a little summary. With the ERISA plans, there's no individual underwriting. And you're going to find in individual coverage, medical underwriting does apply and premiums can be affected by this. And with ERISA plans, there are group rates, and an employer may pay all of an employee's benefits, they may pay some of the employee's benefits. Whereas individual coverage is more expensive than a group rate, and obviously the insurer is going to pay all the premiums. It's their own policy. And with ERISA, legal remedies are restricted. With individual coverage, the badge-based remedies are available in many states. And those are usually found on the state government website, and the insurance badge base per state are listed on this site. So we have our first Q&A. Is this better, my volume?
Hi. If all the attendees can enter in the passcode for today, which is payers, and if you had any questions for Beverly, you can send those over through the Q&A also. Okay, so we don't have any questions so far, so you could just continue with the presentation, Beverly.
Okay, and one thing I will say is that this presentation is not meant to be ERISA focused, and it's just giving you the background of how the process works. And here we're going to get a little bit more into the meat of the whole process and how claims are either accepted, denied, and why lawsuits take place. The first process in the authorization, and you're generally going to find authorization needed more for the higher levels of care. So when you get into intensive outpatient, partial hospitalization, residential care, those levels of care usually require authorization. And some of the lower levels of care of the outpatient generally does not require authorization. And, again, we look at the mental health side, which should not be as stringent as a comparable level on the medical side of these levels of care. The first step would be verification of benefits, and I always recommend that a provider obtain the verification twice, obtain the name and the reference number of the person they talk to as far as the benefits of that insured before admitting them into a program. And oftentimes this is really the first spot where things get a little bit muddled. And in working with different treatment centers, there are many interpretations of benefits or many benefits that may be given incorrectly, and that's why it's really important to document what the providers should document what they've heard as far as what the benefits are for that patient. And then there's the intake process, so there's the pre-certification. And what happens in an intake is that the providers at this particular program, in a partial program, an IOP, a residential, will gather information from the prospective patient in order to make a determination if this particular level of care is appropriate, or does this patient need to be referred to another level of care, whether higher or lower. And these are based on criteria that are set forth by insurance companies, but there's also American psychiatric guidelines that are really the gold standard of care in treatment and outline levels of care. And some providers don't participate with insurance, but they want to offer prospective patients the benefit of insurance. So when the provider is out of network and trying to get authorization for a patient, this is called a single case agreement. So the provider is asking the insurance company, in a sense, will you make this exception for this patient to come into our program on the single case agreement? And sometimes this case can be treated in-network. If there's no in-network provider in the area, often this case can be treated in-network, so then the patient's in-network deductible applies, which probably is less expensive, and then they're not having to tap into two deductibles. And sometimes these cases are put in out-of-network, so that subjects the patient to two different deductibles in and out-of-network, and oftentimes the reimbursement is lower, the patient's copay is higher. So it would be desirable for that patient to have an in-network agreement. And then throughout the process, once the patient is admitted, should the patient be admitted, there are ongoing concurrent reviews. So what happens is that a member of the treatment team will have to talk to a case manager and give an update on that patient's care. It may be every 3 days, it may be every week, it may be every 10 days. It's whatever that case manager stipulates, and the case manager will present questions. That team member, whether it's the therapist, whether it's the psychiatrist, will have to answer those questions. And there's constant collaboration with members of the treatment team. And at some point, the case will need extra review. So this means a denial is potentially coming. The patient is believed by the case manager to not need this higher level of care anymore. It needs to be stepped down to a lower level of care. And they often call these, in the insurance world, peer-to-peer reviews, doc-to-doc. This is where the insurance company physician will need to talk to the treatment center physician and confer as to the need of the level of care. And this physician on the insurance side, often the medical director, will either recommend additional authorization or they'll deny the case and put it to a lower level. And if the case is denied and that treatment center feels that this patient needs to be kept at the level of care that they're at due to medical necessity, then there are various appeal options. Generally, there's a first appeal, and that means that the treatment team or the medical director on the treatment side gets another chance to talk to the peer on the insurance side, confer again, see if there's any change, and generally we find that if the appeal is denied on the first leg, it's generally denied on the second leg, but stranger things have happened. And then if this case is denied from the second appeal and ERISA is not involved in the process, there is an external appeal option, and that's on the state level, and that generally goes to an external reviewer, and then a decision is made. And then, if this fails, if the external appeal fails, then litigation is considered. When I talk about medical necessity criteria versus industry standard of care, each insurance company will develop their own standard of care, and you can go to most insurance company websites and search as far as mental health care and find level of care guidelines for each level of care based on medical necessity. So, for example, the patient has to meet X, they have to meet Y, and in a higher level of care, it may be they have to, if they can't care for themselves daily or follow proper hygiene, or let's say in my work as an eating disorder specialist, they are in their eating disorder behavior multiple times per day. And this generally, you might find references to American Psychiatric Association guidelines, but medical necessity criteria from an insurance company point of view is not the pure APA guidelines. And from a treatment perspective, the provider has to follow standards of care in their industry. So they're going to be following the American Psychiatric Association guidelines. And I've put the website on this slide. So there are guidelines for various diagnoses, and level of care is matched to exacerbation of behaviors. A denial based on medical necessity is then what we focus in on. So the Parity laws require that mental health coverage be provided commensurate with medical health coverage. And for example, if we look at residential psych level, that may be comparable to a skilled nursing facility on the medical side. And there was another issue a number of years ago where some insurance companies would only allow hospital-based facilities to provide partial hospitalization and intensive outpatient levels of care. And then when the Parity laws were folded in, at some point, any off-site hospital could provide, a freestanding facility could provide these levels of care. So again, parity from a medical standpoint. And you see many medical freestanding facilities, technically a hospital-based facility has to be within 200 feet of the hospital. And perhaps in your neighborhood where you reside, you may see several freestanding medical facilities, and this is where the mental health facility is allowed to also be freestanding based on the level of care as well. And we do find that medical stability will occur long before psychological stability. And there are state definitions of medical necessity as well. You can go on the state website again and find these. And the state definitions will trump the insurer's definitions of medical necessity. So a provider will behoove a provider to check on the state website, and these are generally more in line with the APA guidelines. And then you have the issue of physician and respective expertise. Oftentimes the physician on the insurance company side will not have specific training in the expertise that they are discussing with that provider's medical director in determining the level of care needed. And it's really important for the provider to determine the credentials, the experience, and training of the physician on the insurance end, and determining whether the medical director on the insurance end has bias, given previous decisions in specific cases, and does the insurance company rely on certain physicians all the time to make these decisions, And it's important on the provider side to note the credentials of the person on the other end. Verbally state that they've asked this question and document that, because this is key also in whether or not that physician on the insurance side has that expertise to be making a decision on the patient care. With denial based on exclusion criteria, there are various exclusions in various policies, and again, that goes back to if a state has mental health parity or not. So it's important to know the state's involvement with parity health laws, as they may or may not participate in parity. Some of the denials you see may be due to rigidity and what the insurer thinks treatment should look like. For example, if somebody's in a residential care setting, there are family visits, family involvement is very important in the standard of care in the treatment. So oftentimes the family cannot be present if the residential care facility is out of state. So then the family members are Skyped, telephoned, and sometimes the insurer, that's something the insurance may jump on and say, hey, you can't have telephonic treatment, but it's really unrealistic for the family to be present in an out-of-state facility day to day. And there are also issues that insurance companies may have with partial hospitalization and overnight. So for example, somebody might be in residential care, a patient may be in residential care, and then insurance denies that care, suggests that the patient step down to a partial hospitalization program. While they're at residential care facility, they offer a partial hospitalization program as well. And what they generally tend to do is keep the patient overnight in the residential setting. They're offering a partial hospitalization program, maybe a little bit more than normal of what a partial hospitalization offers, but they can legally bill for lower levels of care than what is being delivered. And you find often insurance companies will argue that a facility cannot provide a lower level of care or provide a higher level of care and bill for a lower level of care, but it is legal to do so. And then you may find a selected exclusion of certain diagnoses. And this is where a plan document is really important. And there may be provisions in an insurance document, in coverage documents, where there's no exclusions. And that insurance company chooses to exclude certain diagnoses that is against the policy. There are also denials based on standards of care. For example, the denials don't follow from the premise. Here are some examples. She's not improving much. Therefore, she needs to step down from PHP to IOP. And on the other side, the provider may say, well, wait a minute. She's not improving, so she needs this level of care, or maybe she needs a higher level of care. So these are some of the issues that come up in a peer-to-peer review or in a concurrent review that the provider really has to be prepared for. And if, in fact, this case goes to a legal remedy, then these are all important to know. These are other examples of denials based on standard of care. And let's say A is said to be the cause of B because B follows A. For example, an insurance company claims that because relapse followed treatment, that treatment was inadequate and that was the cause of the relapse. And that is not necessarily true. There are many individuals who struggle with mental illness and they're going to struggle all their lives. And you find relapse, a high level of relapse, which doesn't mean the treatment was inadequate. It may mean that the treatment was not enough, that patient did not have enough time, or perhaps the relapse was not as great as the initial treatment episode. Then there are denials based on irrelevant or false information. And you also find insurance companies that will claim that authorization was not obtained in a timely fashion. And it's important to note that there are state laws for partial hospitalization for residential care that may be different than insurance and insurance industry standards. So, for example, in the state I reside in, the authorization must be obtained within 60 days, or 60 hours of admission, where an insurance industry standard may say 24. So the state will trump. There have also been issues, and I've been in a situation where maybe by mistake or maybe in talking, the clinician stated the secondary diagnosis over the primary diagnosis, and the facility that that clinician is operating in, the primary diagnosis is the basis for the treatment center. Maybe it's just a verbal mistake, and then they're held accountable. Well, we're not going to authorize care because you said the secondary over the primary. And I have actually been in the situation, and thankfully that case manager was able to just back everything out, and we started all over from the beginning and stated the primary diagnosis first. Then there's case shaping. And this is fairly new in the industry, where the provider may be going through a concurrent review, and the case manager on the other end, or the medical doctor may say, hey, we believe that the treatment should be XYZ. You're providing this, and we are suggesting that the patient be provided, they may be suggesting a different medication, they may be suggesting a different form of treatment, and the provider does not necessarily have to follow that, but they do have to document that that was told to them. Then there are denials based on plan discretion. So this is where it gets really sticky. And this is a case that was actually cited. It's cited in many cases that come forth with denial issues, that you often find the third-party administrator, and when I talked about self-insured companies that have a third-party administrator or a TPA that oversees the claims, well, oftentimes the insurance company acts as the TPA for the self-insured company, which is really a conflict of interest. So, of course, that insurance company is going to have their own interests in mind, and cases that have been brought forth have cited this case here, the Metropolitan Life Insurance Company versus Glenn. And this is big because if an insurance company is acting as a third-party administrator, there's a huge chance for bias and a conflict of interest on top of that. And generally, you're going to find the inconsistent or insufficient reasons for the denial based on this conflict of interest. So there are determinations made without supporting evidence, and also a failure to follow planned procedures. So maybe, for example, a patient does follow the appeal process, and the plan discounts that. And perhaps the insurance company or the third-party administrator fails to provide a full and fair review of that denial based on this conflict of interest. And oftentimes, you may find that insurance company / third-party administrator is acting very adversarial, just on their tone of voice. We often find, and even being on the provider side, just that adversarial attitude on the part of the case manager, and that as well is something to be documented. And as far as denials that are unjustified, this is where we bring in the APA guidelines. And if a provider is operating within these guidelines and upholding their standards of care, they're doing what they should be doing. And it's often easy for a provider to get derailed and really has to stand within what they believe. And regardless of what happens in the treatment level, the provider is generally encouraged in their own industry to keep a patient at the level of care that they should be at and then fight the battles later. Now you also get into the external appeal process where in a fully insured situation where the first appeal holds, second appeal, and then there's a third appeal process. So this is called an external appeal. And what happens often is that the insurance company sends this file to their own external appeal group, which is really another conflict of interest because who does that external appeal group have its best interest in mind is the insurance company. Now, with a denial, generally a letter follows this, and a letter has to outline for the provider and the patient what happens next, what the patient's appeal rates are, very detailed. And if this letter does not outline this, then that is a violation of policy. And there's another situation where oftentimes there's no out-of-network providers in the area, and an insurance company may offer out-of-network benefits on the mental health side, but state that in order to provide out-of-network care, you still have to be in-network. So I never understood the rationale behind that, but that has happened. And then there's provider network adequacy versus any willing provider. Oftentimes you see a denial of a single case agreement by a specialist group where the insurance company might state, well, hey, we have these other providers in our network. Now, these other providers in network may not be specialists in a certain mental health area, and I think that this is where mental health has always been treated as one size fits all. There's one mental health disease, where, on the medical side, there's so many specialties, cardiology, oncology, GI. For mental health, there are specialties within mental health, and treatment centers set up for various specialties. And you may find that denials are justified. So on the opposite end of the spectrum, pre-authorization sometimes is not obtained on the fault of the provider. And for whatever reason, the provider feels that they don't have to obtain pre-authorization, we'll just fight on the back end, but that's not necessarily the case. If there is a process in place, pre-authorization has to be followed. And also the provider may have poor documentation, and documentation is really key in these cases in order to outline everything that's happened in a treatment episode. Or perhaps the provider isn't following their own standards of care, or the appeal process isn't followed correctly. There is a time limit to file appeals, and that's generally set forth by the plan. However, there are state regulations in each appeal process, so the state regulations do trump the insurance filing appeals deadline. So if a claim goes to ERISA, then the claimant then is denied, has to be provided a written notice set forth in a manner to be understood by the claimant. So ERISA has to provide a specific reason for the denial. So let's say a case goes through first appeal, second appeal. If the insurance covered by ERISA, then they skip the external appeal. It goes right to ERISA, and then it is under judicial review. And this may also dictate whether or not a suit can be filed. And then specific references to the plan provisions have to be made on how the denial was based. And then any additional material or information necessary with the claimant to perfect the claim. So the claimant can perfect the claim and can turn in more information if the judicial review allows that. So if the benefits are denied in whole or in part, the reason has to be stated in a reasonably clear language with specific references to the plan provisions that form the basis for the denial. And then if the plan administrators believe that more information is needed, they have to ask for this information. Now the claim file is important to have. So any attorney that's working on a case on behalf of an insured will want to obtain the claim file. And this is going to consist of any document, record, any information that was relied upon in making a benefit decision. And this is actually transcripts of a case manager conversation with the provider side, and it's the plan document, it's everything involved in that patient's case. And the insured is entitled, upon request and free of charge, a copy of this. And it's really important for the insurer to obtain the plan document. And in the setting that I was in, we always obtain the plan document even before admission because we wanted to see everything outlined in that specific patient's plan. So we knew that if a patient was going to be denied, was this denial justified or not? And the plan document can be obtained from the employer's HR department, and if the HR department doesn't have it, the HR department can obtain it from the insurance company, and the insurance company has to release this. And then the denial letter, it's really important for the provider to obtain the denial letters upon the denial, and oftentimes insurance companies are remiss in sending these denials, so this would be a violation of policy. And then the internal appeals, that process has to be filed and timely. And the external appeals, if it's a fully insured path, then this has to be filed as well. And then once all of these are denied along the path, then this is where litigation begins. And from a medical record documentation standpoint, it's really important that an attorney taking on a case is going to have a provider on the provider side that is following the APA guidelines, that has complete assessments upon admission, that they have qualified provider as part of the team, that there's follow-up, individual notes, group notes, and as I mentioned, all types of assessments from all different disciplines, and also utilization review notes. So anybody involved on the provider side is going to be doing these concurrent reviews on behalf of the patient. Sometimes a provider or treatment center may have an outside company on their behalf doing these reviews, and it's important that this UR company, or if this is done internally, keeps really detailed notes of entire conversations on each concurrent review. And from an appeal standpoint, when the appeal process is in place, and oftentimes the insured, the patient, will retain an attorney even from the get-go of the appeal to make sure that they're covered in all aspects. And here is just an example of what might go in an appeal letter. Documents are summarized, pointing out inconsistencies of the determination, pointing out irregularities, pointing out omissions, and enclosing any documents such as treatment records, letters of support, journals, videos, any independent medical examination. So really anything that's going to give backing to the case. And this is definitely where legal support is needed. So in summary, various types of health plans will guide the process. Again, going back to, is a plan a fully insured plan? Are they governed under ERISA? Are they a self-insured plan? And you're going to find that the benefits are going to vary for maybe the same diagnosis in a fully insured plan and a self-insured plan. Because in a self-insured plan, that benefits administrator inside of the company can really put together their own plan for their members. And requesting plan documents prior to treatment is really important. So that way the provider can read over all the stipulations in that patient's policy. Knowing the authorization process is important. Documentation, clear, thorough documentation, medical necessity guidelines followed, and evidence-based practice are the key. Also following the appeals process timely, and oftentimes when litigation happens before the appeals process and not in the order it should be, oftentimes the appeal process, the time expires, and that can throw the whole case out. And then also exploring other matters surrounding the case. And that is my presentation. And I'd like to open up to any questions.
We can actually save those to the end, so you can just keep going.
What's that?
Oh, okay, so we do have two questions. If all the attendees can enter in the passcode for today, which is payers, and any questions that you may have. This question is from the first half of the presentation. Do these requirements apply to disability insurance?
Yes, actually, disability, life insurance, that all falls under, it may fall under ERISA or it may not. So all of that is part of that as well, yes.
Next question. Can you present a case study or two to illustrate how this process might work in a typical small business setting?
As far if I understand the question correctly, let's say I'm trying to give an example even from my own practice setting where, for example, we were not in network with a certain insurance company, and we had a patient who needed to access our specialty, and there were no other treatment providers within our specialty in our area within an hour, hour and a half, even farther out. Generally, if it's a partial hospitalization type of setting, there has to be a provider within a 45-mile radius. And the patient in need of this care, and the policy was held under a church, actually. It didn't fall under ERISA, and it was also a self-insured company. So what had happened was the insurance company in this particular case was also acting as the third-party administrator. So they were trying to convince the employer not to make this exception for this patient to enter our level of care, and the employer was paying the benefits. So they were wanting to do this for this member, and the insurance company / TPA was saying, no, don't do it. And ultimately the employer said, we're doing it, admitted the patient. We admitted the patient, and it was treated as an in-network single case agreement, and meaning that this patient's in-network deductible applied, in-network copays. We were billing in a way that was in-network, receiving payments timely that were considered in-network payments. And that is one example. And on the other side of it, we were dealing with an HMO, and generally with HMOs, their visit limits are very, very short. And we really needed to get this individual more care than 6 days of care. So we were able to negotiate in more of an out-of-network, or no, it was in-network, because they didn't have out-of-network in an HMO. We were out-of-network with the HMO. But it was treated in-network, and we were able to document the care needed. And at some point the care was denied, and we did go through the appeal process on behalf of the patient, where the first appeal is pretty simple because it's mainly telephonic, and then the second appeal is more so you're really sending in documentation and the letters, and that was denied, and it went through an external appeal, and in that situation that was denied as well. And at that point the patient did have the option to retain an attorney and begin the litigation process. That patient decided not to do that. And, should that patient have done that, there was so much evidence behind that patient and the care that my thought is that it would have been upheld and the benefits would have been granted to that patient and paid.
And our last question, who are the medical directors that make the decision on treatment? Is this the provider or the insurer making this decision?
Well, the decision on the care of whether to continue authorization of care, that is made on the medical side by, they're generally called medical directors. At least in my experience, this is what the physician who, when the case goes peer-to-peer, they're generally called medical directors. They may not be on staff at the insurance company. They may be in some other state, and they're hired on every case to make that decision. And this is where it gets sticky as far as if the insurance company is relying on that same expert over and over, and that expert is Dr. No, who they're always saying no for whatever reason, then there is an issue behind that.
Thank you, Beverly, so much.
Thank you. Thank you very much.
In addition to being your best source for testifying and consulting experts for more than 60 years, TASA also offers free interactive webinars, expert written articles, research reports and expert witnessing, including the Challenge History Report 2.0 and Expert Profile 360. Just a reminder that if you're applying for CLE credit, you must have attended for the full 60 minutes of the presentation. You are also required to complete the survey at the end of the program. Please note you will be receiving your certificates via email in 24 to 48 hours after the presentation. I want to take this opportunity to thank everyone for attending, and most especially Beverly Price for her time and effort in creating this presentation. If you would like to speak with Beverly, if you would like to speak with a TASA representative, regarding an expert witness for a case you are currently working on, please contact TASA at 1-800-523-2319. One of my colleagues will be following up with you regarding your feedback on today's presentation. This concludes our program for today.